We are live.
Good evening and welcome everybody to the DOS Postgraduate Education Program, DOS PEP as we all know it. And currently we are in the Retina module. And today we are on the 40th class of the DOS PEP and the 18th lecture for the Retina module. We are happy to welcome here Dr. Rahul Meher sir and Dr. Tanya Jain. Today we'll be discussing upon an important topic, that is retinal vasculitis. Retinal vasculitis is a very important topic, as you know, you have cases, both short cases and long cases in your MD and MS exams. So it is a topic that you need to know both for your theory as well as practical exams. You also get short notes on this topic, and hence this topic becomes very important. And I'm sure the speakers are going to cover this topic in depth from both theoretical and practical aspects. We are thankful to Dr. Lalit Verma sir, who has helped us select the speakers on the topic for the Retina module of DOS PEP. Sir needs no introduction. He is currently the Congress President for APU and has been the past President of AIOS and DOS. Dr. Anupam Sachdev sir, he has been very helpful in getting the ANBI collaboration with the DOS PEP, which brings all the NB associated hospitals on a common platform and also helps us get all the DNB students to get on this common platform of DOS PEP. Dr. Rahul Meher sir is a consultant in vitreoretina, uveitis and ROP at Dr. Shroff Charity Eye Hospital. He is also our editor-in-chief of the Delhi Journal of Ophthalmology. He's worked on various studies and projects and has presented various national and international papers, and also has had run instruction courses at the prestigious ARVO conference. Dr. Tanya Jain, who will be talking about the topic of retinal vasculitis, is a consultant on vitreoretina, uveitis, and ROP at Dr. Shroff Charity Eye Hospital. She's done her DNB from Sadhguru Netra Chikitsalaya, Chitrakoot, and followed by a vitreoretina fellowship at Shroff Charity and advanced training from the Boston in uveitis from US. She has over 40 plus publications in peer-reviewed journals and has presented at various national and international conferences, and is also an associate editor at the Delhi Journal of Ophthalmology. And as our secretary has also joined, I would like sir to say a few words before we hand over to...
No, Pranita, please continue. I am traveling, so it will create a lot of noise. So please continue.
Okay. So with that introduction, I would like to hand over the dais to Rahul sir for a few words before Tanya can proceed with the class.
So good evening all. I think it is nice to have people understand about vasculitis. I've asked Dr. Tanya Jain, who's my colleague and vitreoretinal specialist at Shroff Charity Hospital, to help me out with this presentation. She'll be presenting it. I'll be kind of moderating it. Thanks, Dr. Praful, Dr. Pranita, for giving us the opportunity to present this class. So I think, Tanya, please proceed with the class.
Hello and good evening, everybody. So I'll just share my slides. Okay. So before I start, thank you, DOS and Dr. Rahul, for this opportunity today. So I'll be talking about retinal vasculitis. So we'll be covering this class on these 5 major agendas. First, the definition, how do we classify retinal vasculitis, what are the common types. Then I'll be sharing a few representative cases of retinal vasculitis that we have managed, and then we are open to discussion. So retinal vasculitis is a sight-threatening inflammatory eye disease affecting the retinal vasculature. Basically, retinal vasculitis is kind of a misnomer. It is actually retinal perivasculitis. In autopsy studies, whenever they do a study from these vessels, there is infiltration around the vessels, which could be the veins or arteries or both. So if predominantly the veins are affected, it is known as periphlebitis. If predominantly the arteries are affected, it's called periarteritis. And if it is a combination of both, it is angiitis. Yeah. So this diagram looks very, very complicated. It really doesn't have to be. All we have to understand is that there could be 2 types of, you can say, stimuli for this vasculitis to occur. These could be exogenous factors or endogenous factors. These factors, they go to the antigen presenting cells, which release a lot of cytokines. These cytokines affect the B cell, which in turn release a lot of auto antibodies, and they lead to tissue damage and endothelial cell dysfunction. So basically, everything what is happening is a lot of release of a lot of cytokines, which lead to B cell activation and the activation of the immune system. So vasculitis could actually be of four major types. There are actually a lot of classifications for vasculitis. None is really the accepted one, but infectious vasculitis, non for the ease of understanding and for the ease of this class, infectious, non-infectious, or primary or isolated vasculitis, or masquerade. So if we look at this list, there could be a lot of infections like bacterial, viral, or parasitic, a lot of non-infectious diseases, isolated ocular disorders like IRVAN or sometimes intermediate uveitis, or masquerade syndromes like leukemia or ocular lymphomas or paraneoplastic syndrome, which could present as vasculitis. Well, this is a big list to learn or evaluate. Can we have some hints? Yes, the retina is actually a window into the body, and it gives us a lot of hints. When you see these patients, first you should look which vessel of the eye is primarily involved. Is it primarily periphlebitis or periarteritis? Like in this picture, you can see that there is a lot of inflammation, lot of vasculitis, which is primarily along the veins. So there is along with these hemorrhages. So this is primarily periphlebitis. An easy way to learn is that most of the infectious diseases would cause, periphlebitis. This is just an easy tip to learn. This is not a generalized, statement that I'm making. Just an easy thing to learn is that mostly the infections like TB or Eales disease, HIV would cause periphlebitis. Apart from that, Behçet's disease, which is very one of the major causes of retinal vasculitis or sarcoidosis, is also into this periphlebitis category. Second is arteritis. So arteritis, again, an easy way to learn is that most of these systemic causes, the systemic vasculitis like Wegener's, like SLE, Churg-Strauss syndrome, eosinophilia, all these, they primarily cause arteritis and arterial occlusions, not venous occlusions, because mostly things are happening in the arteries. So again, if you see a patient with a lot of cotton wool spots along with vasculitis, think of these systemic diseases like SLE, Wegener's, and cryoglobulinemia. If you see a lot of intraretinal exudates, think of syphilis or think of rickettsial diseases. If you see a lot of necrotizing retinitis in the retina, think of ocular toxoplasmosis or viral, like ARN or CMV retinitis. A picture like this, where you can see a necrotizing patch of retinitis with a lot of exudate. I'll just show you this. This is almost like a frosted branch. All the vessels of the retina, there's vasculitis, along with this patch of vasculitis and hemorrhages. Again, if along with vasculitis, you see aneurysms in the retina, think of IRVAN or sometimes even sarcoidosis, which could be associated with granulomas. Frosted branch andritis, it is a typical picture where most of the vessels of the retina are fully, there's sheathing along the vessels. Again, think of SLE or even masquerade. So these are the hints that the body will give you. Again, if there is occlusive vasculitis, which means that there is periphlebitis, veins are involved with ischemia, with occlusion, most often than not, it's TB or Eales or Behçet's. These three would be my main differentials. If you see inflammatory BRVOs, these are again occlusions, but of the venous category. Think of the periphlebitis, Behçet's, TB, or sometimes sarcoidosis. So these patients Sometimes, more often than not, they can be asymptomatic because these vasculitis patches are lying somewhere in the periphery. They may be associated with sometimes with floaters. However, when they develop some NVs, they may come with recurrent vitreous hemorrhages or sometimes just scotomas. So in the exam, you will be asked about the signs. A very easy diagram to remember is that there could be vitritis, there could be vitreous hemorrhage, which is always shown in green. There could be NVEs in the retina. There would be yellowish sheathing along the vessels, and the disc, more often than not, would be hyperemic. Or sometimes you could have NVDs or inflammatory neovascularization in the retina. So since we saw so many causes of vasculitis, we don't go around working up the patient for everything when we see. So we look at the clues and we always direct our workup towards that diagnosis. So first, when you see the patient, something known as meshing. Is it unilateral, bilateral, granulomatous, non-granulomatous, acute or chronic? Which area of the retina is primarily involved? Is it anterior? Is it intermediate? Is it posterior? Or whether it is occlusive or non-occlusive vasculitis is very important and helps us to kind of tailor our investigations and reach to a diagnosis and give the specific treatment. This is a flowchart that I found in one of the articles. Even though this is not an Indian article, so not very much associated with our scenario, you won't see a lot of TB here. But a very easy way is that if you have a patient with vasculitis and there is some systemic disease with retinitis, you look for the viral causes. If there is occlusive vasculitis, you go more towards TB, sometimes SLE, or again Eales and Behçet's. And if it is non-occlusive, we think of all the systemic vasculitis that we all learned. And if there is no evidence of any systemic disease, then we think of the idiopathic vasculitis or things like IRVAN syndrome. Another important thing to remember is that you might not always get an acute presentation of vasculitis. The picture here, so the picture here is acute. You can see this vessel, there is vascular sheathing with hemorrhages. So this is an acute case. You might not get an acute case every time. Sometimes you may get a burnt out or a chronic disease where you see these occlusive or sclerosed vessels. It's very important to differentiate an active from a sclerosed vessel, and you see that in an active vasculitis, there would be fluffy, whitish exudates along the vessels, and in these sclerosed vessels, there would be, the kind of burnt out situation of the retina. Then sometimes these patients, as I said, they may present with NVEs or neovascularization, which could be sometimes inflammatory or due to ischemia or occlusion. And these NVs, if not treated in time, sometimes the patients may present with vitreous hemorrhage or rubeosis or neovascular glaucoma. So these are all the spectrum of retinal vasculitis and what it can do to the eye. So with this basis, I'm gonna move quickly to some of the representative cases. Ma'am, do we have any questions up till now?
No, Tanya, we'll take all the questions in the end.
Okay, great. So my first case is a 22-year-old female who came to us with diminution of vision in the left eye since 9 days. This patient gave a history of recurrent oral ulcers, and she also had her extremities which look like this. So there's a lot of pruritic rashes on her hand, pruritic rashes on her feet, and her angiogram shows an IVC, which is your inferior vena cava obstruction. Her fundus picture looked something like this. Her right eye was fine, but in the left eye, there is some disc pallor associated with very, very active vasculitis almost in all of the quadrants. There is macular edema, and her vision is 2/60. This is what her periphery looks like. There are a lot of hemorrhages and vasculitis. So we can see that this looks like primarily periphlebitis in a patient with systemic manifestations, pruritus, her rashes, and vena cava obstruction. So this is what her OCT was like. There is a lot of cystoid edema, active inflammation. On FFA, her disc is leaking, and all the vessels in her eye have lit up, suggestive of vasculitis, along with areas. I don't have the peripheral images, but there were areas of occlusion as well in the periphery. So we did her whole workup. Her HLA-B51 came positive. Behçet's was confirmed. The patient was started with intravenous methylprednisolone on steroids, put on long-term immunosuppression with methotrexate. And this is what happened after 3 months of treatment. Because of this widespread ischemia, there's a lot of disc pallor in her eye. Her vision has improved, not too much, around 560. However, all her vasculitis has resolved, and her feet and her hands look so much better, apart from that ulcer on her foot, again due to ischemia and her vena cava obstructions. So Behçet's disease, you may get a short note or a long question also on this. I think if you remember this case, it will be very easy for you to write all the signs and symptoms of Behçet's disease. It is a multi-system inflammatory disease with periodic recurrences causing obliteration, necrosis, and fibrosis of the vascular system. It causes recurrent occlusive vasculopathy affecting both veins and arterioles. However, predominantly it is periphlebitis. There are oral and genital mucosa could be involved, and eyes are involved. So this is the diagnostic criteria for Behçet's disease. Major criteria includes recurrent oral ulcers, skin lesions, recurrent genital ulcers, and ocular inflammatory diseases. These 4 points must be remembered. Apart from that, patient may have GI ulceration, arteritis, systemic vasculitis like this patient had. This is again a representative image. You already saw a very nice treatment. One thing that you must remember is that whenever there is disc edema, disc involvement, a prompt intravenous method, prompt pulse dose of steroids is needed to, kind of really calm down the inflammation that is happening. Behçet's is a very, very difficult disease to treat, and a lot of recent studies have shown that there is a lot of TNF in the AC and the vitreous of these Behçet patients. So adalimumab is now kind of a drug of choice for these patients. However, if non-affording, cyclosporine, azathioprine, methotrexate are the other options. Again, infliximab also has a role in vision-threatening diseases. But adalimumab, if asked a question, is the drug of choice for treating these patients. Now, my second case is a 45-year-old male resident of Aligarh. History of cough and expectoration. Vision is 6/60 and 6/6 in right and the left eye respectively. So look at this. In the right eye, there is massive vasculitis along the major arcades, along with a big with a lot of hyperemia of the disc. And if you see in the left eye, there is an inflammatory branch retinal vein occlusion. You can see this vasculitis causing an occlusion. However, since there's no edema in the macula, the patient is 6/6 in the eye. However, there are a lot of vasculitis. Again, you can see it is primarily a periphlebitis. We must think of Behçet's, TB, those kind of things. Her FFA revealed again a lot of leakage from most of the vessels and the occlusion site causing a lot of leakage. This patient was Montux positive, and CCT was suggestive of TB. The patient was started with ATT and oral steroids, and you can see how beautifully the patient has responded in both the right and the left eye. So again, another case, 18-year male from MP, diminution of vision since 4 months, family history of TB, no previous episodes of pain or redness, and no systemic illness. This is what the right and the left eye, you can see the right eye vasculitis actually looks a bit in the resolving kind of phase, but in the left eye, there is a lot of active, vasculitis with some, you can see these choroiditis type of healed, tubercle type of patches also. The macula was fine. And on the FA, you can see the staining of these, old tubercles. However, in the left eye, there's a lot of leakage and a lot. So these are specifically the non-perfusion areas in the periphery showing a lot of leakage. So this was again TB vasculitis, and the patient did well after ATT and steroids. So TB is very, very important, especially in a country like ours. We all know that a lot of patients may not have lung findings. They may have just ocular findings. So what are the most common ocular findings of TB? There is definitely choroiditis, multifocal or focal, or serpiginous like choroiditis. Lot of tubercles or large granulomas called tuberculomas, sometimes neuroretinitis. There could be subretinal abscesses, and definitely retinal vasculitis, which is ischemic or occlusive type. Uh, Again, a representative picture similar to what we saw in our patient. This is actually a choroidal granuloma in one of the TB patients. So, okay. So a very landmark paper by Dr. Gupta showed us what, so if you remember this table, you'll always remember what could be the manifestations of ocular TB. These are actually the manifestations with granulomatous uveitis, tubercles, tuberculomas, serpiginous like choroiditis. So if any of these ocular findings are present, along with ocular investigations include demonstration of TB bacilli from an ocular sample, it is confirmed. However, if along with this there is a positive MON2 test or active or healed evidence of TB on the chest X-ray or CT scan or an IGRA, this patient has presumed ocular tuberculosis, must be promptly treated with ATT, if only I probably for a longer duration, even though there's no consensus on this, but at least for 9 months, and oral steroids. Okay, so this was about TB vasculitis. My another case is a 32 year. So from Behçet's to infectious, now we go on to primary vasculitis of the eye, known as IRVAN syndrome. So this is a 32-year-old male resident of MP, came with both eye diminution of vision since 25 days. He gives a past history of vasculitis VH for the right eye. Right eye, there was a lot of edema, not visible. However, this is what the left eye looked like. So you need to look very closely on this. Just if you see the disc, yeah. So if you see the disc, there is some hemorrhage or neovascularization or hyperemia of the disc. Along with this, you can see this aneurysm kind of thing. And along with that, periphery, there are a lot of sclerosed vessels, or could also be active. We will see with the FFA. So there is some form of neuroretinitis, there is aneurysms, and there is sclerosis there is vasculitis. And it was fine, the OCT was fine. But if you look at the FFA, you can see that the whole of the retina is ischemic, the peripheral retina. Only this macular area and bit of the nasal area is vascularized. Otherwise, there is widespread ischemia. In this patient, a diagnosis of IRVAN was confirmed. The patient was given PRP and IOP management, started steroids, and the patient did well. So what is IRVAN? IRVAN is idiopathic. You don't really know a cause. First, you have to rule out all the infections in these patients. Idiopathic retinal vasculitis, aneurysms, and neuroretinitis syndrome, or IRVAN. It is uncommon. However, one must think of it if you've ruled out most of your causes, and if you see this particular type. And again, it is also a question for your MS or DNB exams. Usually healthy young with more of a female predisponence. It could present with periarteritis is non-familial, and most of the investigations are negative. So they have three major criteria. First is your retinal vasculitis, aneurysmal dilatation, mostly at the arterial bifurcations, and neuroretinitis. Then sometimes the minor criteria include capillary non-perfusion, retinal neovascularization, and sometimes even exudation. If untreated, you can see this is a subhyaloid hemorrhage. These neovascularizations may bleed and they may also present to you with such a picture. So there are stages. If it's only macroaneurysms, neuroretinitis, and vasculitis, it's usually stage 1. If there are non-perfusion areas, like in our patient, it's stage 2. If there is neovascularization, disc elsewhere, or vitreous hemorrhage, stage 3. If it has also gone to the ischemia to the extent of anterior segment with NVR, it's stage 4. And stage 5 is neovascular glaucoma. On FFA, you will find dilatation, and where these things are the pooling of these aneurysms along with peripheral non-perfusion areas. We need to treat these non-perfusion areas and sometimes give even Ozurdex or anti-VEGF. There are some papers which say that unless you see these NVDs or NVEs or the ischemic area do not involve more than 2 quadrants, treatment could be withheld. However, in a country like ours where follow-up should not be a dictum. Another case is, so now we have from this, we go on to another case. This is a 34-year-old Asian female who has come to us with painless diminution of vision for right eye for 3 to 4 days, no other systemic illness. Her right eye is 360, left eye is 6/6. So if you see this picture, the first thing that should come to your mind is definitely there is a lot of vasculitis, but do you see these cotton wool spots? A lot of cotton wool spots along with hemorrhages, and the appearance is almost like a frosted branch. The frosted branch means most of the vessels have continuous sheathing. This is the right eye, and the left eye was fine. On the FFA, block fluorescence along the hemorrhages, lot of leakage from the disc. However, notice one thing, there is no occlusion, no ischemia in this patient. So it is a non-occlusive vasculitis, mostly frosted branch, with giving you a hint of these cotton wool spots. So along with, there was some CME in this patient. This patient came out positive for anti-Ro and LAS. So this was actually a patient of Sjögren syndrome. Gave him intravitreal Avastin for the cystoid edema. Started the patient on hydroxychloroquine and steroids. The patient did very well, and these hemorrhages started resolving. This is an example of one of the systemic vasculitis that we were talking about. Another case is a 23-year-old male who came with diminution of vision since 2 weeks, no history of fever, vision 260 and 660. So if we look here, we see a retinitis patch at the macula along with more frosted branch like picture frosted branch angiitis. Looking even closely, you can see this big retinitis patch at the macula. The patient's CMV IgG came positive. He was diagnosed as CMV retinitis and given intravitreal ganciclovir and deca bi-weekly injections and started with oral antiviral and oral steroids. The patient is still under follow-up. However, you can see how well the patient is responding. So after this, we have covered firstly the Behçet, the periphlebitis kind of spectrum with TB vasculitis. Then our third case was about IRVAN, which was our the primary isolated vasculitis, then the frosted branch and the viral form of vasculitis. Now, once you've ruled out everything, we go to Eales disease. So Eales disease is actually said to be a diagnosis of exclusion. when you don't have anything, however, you have massive periphlebitis, you think of Eales disease. Very, very important question for PGs because most commonly it is most common in India and the Middle East. We see a lot of patients. Usually, you will see males, more common in males, middle-aged males coming with, sometimes floaters or sometimes with vitreous hemorrhage and mostly bilateral involvement. There is chronic and incomplete vascular occlusion, and it is again a occlusive type of vasculitis. So, however, there have been many reports where they say it is kind of an hypersensitivity to the tubercular protein. So, it has been linked again to a lot of tuberculosis in our continent, in our part of the world. Symptoms would be, as I said, sometimes asymptomatic. Patients may come with floaters, specks, or cobwebs. On examination, you may seldom see anterior segment is not that involved. However, you see a lot of vitritis, dilated veins with exudation, vascular sheathing, and hemorrhages. So, a very diagnostic classic of active. If you see the patient in an active state, you will see this. However, if the patient comes to you later, because if you see this, the macula is completely fine. So, this patient may not even be symptomatic. However, due to this ongoing process of inflammation, the patient will develop neovascularization and bleeding, and sometimes you may see the patient in that stage as well. So here on the FFA, you can see this black area is the area of non-perfusion, and these arrows point to NVEs. So, as I said, there are stages. In stage 1, there is mild periphlebitis. Then it involves to the larger veins, then to the new vessels, and recurrent vitreous hemorrhages can lead to tractional or sometimes even combined retinal detachment. Differential diagnosis would include PDR, CRVOs or BRD, or usual venous occlusions or sickle cell hemoglobinopathies. Sometimes sarcoidosis. Didn't talk much about sarcoidosis here, but I will after this, and SLE. So the treatment is definitely corticosteroids. If there is any this thing of evidence of TB, then maybe a course of ATT also, and sometimes immunosuppressive drugs. Retinal ablation is very, very important. These ischemic areas need to be lasered off in order to prevent recurrent bleeds, and again, vitrectomy would be the treatment if there is recurrent vitreous hemorrhage. Then coming to sarcoidosis. So sarcoidosis, you would usually not see it just as vasculitis. However, I just put it here because this characteristically they present with these candle wax drippings. When the candle is burning, the drippings in the side, that is how it has been described, and associated again with granulomatous uveitis, a close differential with TB. This is the diagnostic criteria for sarcoidosis. You may need to learn this for your exam. Ocular signs, mutton fat KP suggestive of granulomatous uveitis. You may have trabecular meshwork nodules, the snowballs or string of pearls in the vitreous. Sometimes chorioretinal lesion, active or inactive multiple chorioretinal lesions. Again, as I said, segmental periphlebitis, which is your candle wax drippings, optic disc granulomas, or sometimes even solitary choroidal nodules, and bilateral involvement. These signs you must know for sarcoidosis. So treatment is definitely starting with steroids. However, patients do need long-term immunosuppressions, starting with sometimes methotrexate and azathioprine, and later maybe sometimes going to biologics. So before I stop, a word about ultra wide field or wide field angiography. It is here and it is here to stay. If you look online, there would be lots and lots of articles. Sometimes I know in DNB definitely you can get these questions about the usage of wide field angiography, especially in vasculitis. Vasculitis would be one of the most important use of wide field angiography, owing to the fact that most of the things are happening in the periphery in vasculitis. Apart from that, in order to monitor treatment, you're giving the patient immunosuppressants. You can do a repeat FFA to see if there is still leakage and how do you need to taper off your medicine. So before I stop, I would just like to I'd just like to say that don't. I would say that don't do all investigations. Don't do everything. Uh, a good look at the clues and make an informed choice about investigations and the management. So thank you.
Thank you, Dr. Tanya, for that
Thank
wonderful.
you, Tanya.
Yeah.
I think it was a lovely presentation. Uh, two, three highlights. If you don't have a white field, please again do a FFA. Don't just wait for a white field for an FFA. It's a very important part of a vasculitis patient. When in India, I think it is very important to rule out tuberculosis on all vasculitis patients. This is one thing. Yes, there can be multiple reasons from Behçet's to sarcoidosis, which is again a DD. But in these patients, it is very, very important to rule out tuberculosis. Being in India, I think the most common problem. Uh, in my clinical practice, I sometimes eh, start ATT in suspicion also.
Right.
Suspecting a patient with a vasculitis where I'm not able to find any specific reason, I start them on ATT along with steroids. Again, a role of angiography is to rule out CNP areas, neovascularization, again very important. If you have lot of CNP areas and of course neovascularization, please go ahead and laser these patients. Otherwise, at some point in a later stage, they might bleed. So these are very important tips where we what we need to follow in these vasculitis patients. Any specific questions, I think we'll be very happy to take them.
Yes, sir. Thank you for raising those valid points. And I think Dr. Tanya did a brilliant job by showing all those difficult and peculiar and atypical cases, which I think all the time residents do not see it. Very rarely that we get such cases, but once you see that, then you would start getting confused as to what it is all about. So thank you for showing all those beautiful cases and images. So just a couple of questions that have come up from the residents. One of the resident has asked that in a case of vasculitis, if there are no systemic features, should we advise all the panel of tests, or there is an algorithm which one to go for first and which one to go for later?
Um, so I think my whole talk it was about this. So you must kind of look for the clues. So as I said, if it is primarily, veins are involved, then first I would go, with the usual investigations with ruling out TB, or some maybe even I could rule out Behçet's if there are other systemic features. But I would go for TB or infectious etiologies first before I actually advise ANA or something very expensive to the patient.
Okay.
Yeah.
So we need to understand we are in India and doing
Yeah.
tests worth 20-30,000 rupees is not easy.
Not easy.
So very basic investigations we should start with. Yes, if we are not able to find a cause, as Tanya mentioned, veins involved, suspect TB.
Yeah.
First DD. If you see anything beyond it, then yes, it's valid to go in for other investigations. So my take will be start slow. Very important if an infectious etiology, start steroids under the cover of ATT. There is no harm in starting ATT. Yes, I would still go ahead with these government organizations for the ATT part, but believe me, there have been instances in my private practice, in my practice also in Shroff, that when we start with these TB centers, what happens is the vasculitis resolves with the TB, but there are a lot of recurrences because what the government gives sometimes is not the whole course.
And
So my
as I already mentioned too, that if it is mostly ocular TB, a longer duration would be required. Sometimes we even go up to a year for, these
yeah.
patients. And actually, recently I had a patient of miliary TB, and she was taking TB, ATT from a dot center, and she stopped at 6 months. She was responding so well, and then, there was another recurrence. So
So the
you
dots
have,
actually the program they don't have anything known as empirical
Yeah.
therapy. But in practice in retina, uh, so many times in choroiditis and vasculitis, we end up giving empirical therapy of ATT. So it's a very important thing which we must note. I think it's more of a clinical judgment than anything else. Even in dots, I sometimes tell the patient, please spend some money rather than going to dots. Because I've had recurrences in patients who have been taking dots treatment, and I've been having patients who take private. I will not emphasize on taking a private treatment, but yes, it helps. Ankur, any comments?
Sir, first of all, well, at the very onset, I would like to thank Tanya. You have presented beautiful cases. It was the complete spectrum of disease, and I think nothing was left. So you covered the tubercular vasculitis, you covered Behçet's, and everything was covered. So as we are discussing, TRV, tubercular retinal vasculitis. So very rightly said, sir, that ATT is something that we should have a low threshold because we are in an Indian endemic region. At the same time, sir, we should always keep our handfuls with tests. Like if we get a Montux positive with a CCT chest positive, because when these patients have legalities. So me being in a government setup, what happens is that I have seen patients who are coming with ethambutol toxicity when we start with these patients in ATT. And then the vision loss that they have can lead to litigation. So starting ATT having low threshold is must is a requirement. But at the same time, getting your basic investigations done is also needed. And how is that? How is should we proceed with these patients? Because these, as Tanya said, that every patient comes with a telltale signs. So if you see a patient of vasculitis with with hemorrhages, with obliterative kind of vasculitis, an Indian endemic region, probably you're looking at a TB vasculitis. On the contrary side, if you see those candle wax dipping, then probably you're looking at a patient of sarcoidosis. So you have to search for those clues. At the same time, apart from the lasers that you just described, that we should put after that, the hemorrhages have resolved, the active phases out, to prevent any further progression of NVE or vitreous hemorrhages. We can also add anti-VEGF to these patients. They take care of the early stimulus that this thing is secreting from the site where you are still having hemorrhage, you cannot laser. So, if you take care of all the spectrums, your patients do turn out to well. So that's all I have for trabecular vasculitis.
So actually, vasculitis is a very important topic, and I've been seeing a lot of young patients in my practice. Uh, I would say 75% of my patients end up with tubercular vasculitis, some form of Eales, and they respond very well. Yes, I agree. This ethambutol toxicity is a big headache. I've been noticing it off late, but still, most of these patients end up with this tubercular kind of vasculitis. So I think I'm not saying all patients are TB vasculitis, but yes, 70-75% being in India end up with these vasculitis.
So
Uh,
we
Tanya, just
really don't want to give you a message that for every patient of Eales you should start ATT. No, that is not. If you see vasculitis, and so if you see the classification of ocular tuberculosis given by Professor Gupta, if you have ocular findings suggestive of TB along with some systemic, something, Monto is positive, there are some findings of old, even if old COX on the chest X-ray, or IGRA is positive, then maybe you are warranted. If nothing is positive, don't go ahead and start ADD. However, if the patient is not responding even after multiple, 2 or 3 courses of steroids, in very rare scenarios, we, take up this decision of starting an empirical ATP. So maybe what Sir was saying is that not confirmed, but at least probable ocular tuberculosis, which sometimes people don't treat them. Those must be started, but they are defined as probable ocular tuberculosis according to the classification.
and whenever we are starting,
Also, a CT chest, as Dr. Ankur
CECT,
mentioned,
actually
is a very
contrast
important
enhanced is the
test.
best.
Yes,
Yeah.
CECT chest is a very important test. I
so
usually bank a lot on CT chest.
Yeah.
if I have these nodules on CCT chest, I go ahead and give empirical in a lot of my patients in my
One
practice.
one more thing that we should be monitoring these patients whenever we start the ATT, we should also be monitoring their LFTs, because sometimes there have been
Yeah.
few patients who get deranged LFTs because of the ATT. So, at the end of the day, it's when being an ophthalmologist, you are doing, you're going into the domain of a pulmonologist and starting ATT, you should always keep a check on, the LFTs and the other parameters, so that, at the end of the day, the patient gets well systemically as well as, ocularly. So Tanya, just one question, because this is some questions that my residents do ask, and I think the residents who are listening to us right now must be having this. How do we follow up these patients, and how do we come to know that this patient we can stop steroid? How we taper steroid in these patients? So these are the questions that they ask when
In
vasculitis,
which patients, sir? In
uh,
all
uh, PV vasculitis, in mostly that we
TB
see.
vasculitis? So if it's TB vasculitis, you just give a steroid course along under the cover of ATT, and then you just taper it off routinely. Like I routinely taper off my steroids very slowly, which means that once it reaches 20, I may take 2 to 3 months to actually completely stop the steroids. Uh, Another way could be do an FFA. If you do an FFA when your patient is at 5 mg, you do an FFA. If you see that now there is very minimal leakage or there's no disc leakage, it means that your disease is under remission. However, if on the FFA you see that there is actually, you would be surprised to know if you start doing FFAs of these patients that uh, if you see that there is still really active vasculitis, then if it is TB, definitely don't give immunosuppression unless it's very, very bad. That is also under a physician guidance. But if it's not TB, that is a good way to know that this patients need immunosuppression, and just by giving steroids, it's not going to get better.
Thank you, Tanya.
So in infectious kind of TB, it is very important to have a ATT under the cover of steroids. Both work simultaneously. Yes, ethambutol toxicity, again, I would emphasize, is very important. But I think the primary aim is to save the eye. So these specifically Eales patients or these TB patients, as Tanya mentioned, they bleed a lot. Very fast they get to these new vascularizations and they bleed a lot. So my
But I
take will
think
be
that's also happening because there is a lot of underutilization of FFA. Like
yes.
people, they would just start
FFA is
steroids.
very, very, very important test in vasculitis. Very
If
important.
you see, if you do an FFA, especially in an occlusive vasculitis, you will early on see CNP areas. You can early on,
Yeah.
give
You
them
should go
laser,
to
and they
laser
would
very
do
fast
well. Yeah.
because you can gather a lot of information.
Just to add on to the discussion, another resident has asked a similar question, that is Montaux positivity enough to start ATT in a case of vasculitis with no systemic features and normal HRCT chest?
That is $1 million question.
That is the question.
I would not start only on Montus,
No.
personally speaking. Yes, I would require some more information, but yes, if I have a vasculitis bilateral young male with a Montus positive, with a normal CCT, HRCT chest recurrence, I would.
I would ask history of TB exposure.
Yes.
If there's
In
a
the
family
family also.
history,
Family.
Believe
if
me,
there's a
it's a very
family
important
history,
question.
maybe I would give. Maybe
Yeah.
I would. If there's no family history, or
Yeah.
actually sometimes in such patients, if you have a very high suspicion, I now I mean I don't know. This is not actually PG level, but sometimes you may even go for a CT abdomen for such patients because you may sometimes find or spine as well to find some TB bacilli. So basically, we're trying really hard to find some evidence of TB in that patient, and even after that, these are the patients where your clinical judgment, you may take a call based on the morphology of the vasculitis to start ATT. But I'm not here to say that every patient of Eales start ATT. All these variables are there, definitely.
I would
Another
also say the same thing. Every patient of Eales or a simple Montus positive,
is
I
not
would not start
yeah.
ATT here.
Yeah.
Another question, sir. Quick question. What investigations should we do before giving pulse methylpredase? That is the treatment that we are going to give to these patients.
we need to do definitely, apart from the routine BP and everything, we need to do an ECG. That is what we usually follow in our this system. You don't always need to rule out TB because sometimes, Montux will take time and CCT will also take time. And IV pulse, usually you're giving when it is a very desperate situation, the choroiditis pat or something is really, threatening the macula. So, and we always give it
But
under a guidance of a physician.
the old school thought, and the examiners often like to listen to that. Montux and
Yeah.
chest X-ray at baseline will be,
Base. Ideally,
yeah.
yes. Ideally, you should do that. Yes.
Before you give the first dose. So
Before you give the first
for
dose.
your exam purpose, chest X-ray and
Yeah.
Montux is the baseline that you would
And
obviously.
an ECG is
Yes,
very
and
important.
ECG. Another question by the resident: can we start as an ophthalmologist start immunomodulators on our own? And if so, which one should we choose as the first one?
In TB, never.
No, not in
Yeah.
vasculitis. The question is on vasculitis.
So again, it depends on the type of vasculitis. You are a doctor, you can, but if you have the confidence to, or you have, some kind of training in dealing with these immunosuppressive agents, you can definitely start immunosuppression. That's not a very big problem. However, half-baked knowledge about immunosuppression may harm the patient. Lot of litigation that side. So I honestly, I do start patients, but I always have, at least a initial kind of workup done by a physician. Yeah.
A basic workup is very important.
Basically,
I think at PG level, I will not recommend starting immunomodulation on their own. Initially, I took 5 years. I still am very careful. I think after Tanya has come after this training from the US, I have been more confident in asking her, okay, to start or not. But personally speaking, till date, immunomodulation should not be started on your own. We have to be very careful about these things because they can lead to a lot of damage.
Yeah,
as a
life.
So
PG,
my
I would
personal
say,
take will be no, at PG level, 100% no.
Take an
But
opinion of the
yes,
rheumatologist.
yeah, please consult a rheumatologist or a proper, at least a physician who has some knowledge about this thing to start.
Please,
but exam, if anybody asks, you should know that you should never give any immunosuppression in infectious diseases. In TB,
Very
if
important.
somebody says कि methotrexate दे दो in TB vasculitis, never. Never. At least unless the patient has, मतलब वो तो that is different. That patient has taken ATT and everything. But in infectious, never. But yes, there are some indications where immunosuppression is warranted, like sympathetic ophthalmitis, BKH, Behçet's, or all these systemic vasculitis, SLE, etc. So if anybody asks you what are the indications of starting immunosuppressions in uveitis, these 5 things, if you say, full marks. SO, VKH, Behçet's, and SLE. These are the things where you should definitely, and rheumatoid arthritis, juvenile rheumatoid arthritis. These 5 things, if you say, you'll get full marks. And never say TB.
Yeah. So very nice points raised by Dr. Tanya and Dr. Rahul and Dr. Ankur. And I think with that, the questions that I have received are exhausted. Any more questions, Dr. Ankur, from your side?
None. I think we've covered everything.
Yeah. So thank you for all the
Nice presentation, Tanya. I think very good.
Thank you, sir.
Very apt. I would like to thank Dr. Pranita, Dr. Ankur, Dr. Praful, DOS. I think for giving us an opportunity, we'll be happy to take more such classes for the PGs. Being a retina specialist, we are having a MedRet program also. If any PG is interested, they can join on 22nd and 23rd of February. Thank you so much.
Thank you so much.
Thank you, everybody. Thank you for
Thank
the
you, Rahul
opportunity.
sir, and Dr. Tanya.
Thank you, Pranita.
For your valuable time, sir. This is just a small token of appreciation that Dr. Praful sir is giving to all the speakers and all the presenters and all the moderators. And a frame certificate is going to be given in the annual DOS conference. So Tanya, sir is going to be there. Tanya also has to be there to be receiving this.
Thank you so
Definitely.
much. Thank you.
Thank you.
Okay, welcome, sir. Good night.
Good night.
Good night, everyone.
Good night.